Welcome to Sniff This, the podcast where we pull back the bed sheets on skilled nursing facilities, educating, entertaining, and occasionally risking being reported to HR. Awesome. We're excited to be back today with my friend Bruno on this episode of Sniff This. And we'll get into probably some heavy stuff, but we'll try to keep it a little light. Our discussion today is really going to revolve around behavioral health in a SNF setting. A lot of these things there's so many ways to take this, but I'm excited to talk about maybe just some simple remedies and things that we can do to really help some of these patients in a skilled nursing facility setting. But first, I'll have you introduce yourself, kind of your background. How did you get stuck in long-term care? What are you doing here?
That is a great question. And that should be asked to anybody who works in long-term care.
And why are you staying?
And why am I still here?
Yeah.
So I started off, so I'm a nurse practitioner. I do the psych and then also a license for like family practice. And so nurse practitioners can get several types of licenses, similar to other medical professionals. And I started out in the cosmetic space. And which is not
well, there's more money in the cosmetic space, right?
A lot more money, and it's sexier, right? Like you're like, oh, I do lipo or I do this or that.
I could do some Botox injections,
right? And it's like the most hollow environment I've ever been in. Yeah. It's just like so superficial and like all that stuff. And here's the thing: there are awesome professionals that like get into the nitty gritty of cosmetics and stuff like that, but that's just not me.
Right.
I can't do the mental gymnastics to make myself like really like it. And so I did that for a while, and then I just got pulled away because at the time I was doing probably 14-hour days in the cosmetic space. And when you're doing the cosmetics, typically your hands are occupied. And so I like never saw my family, my kids and all this stuff. I did it for a couple of years and I was like, ooh, I don't know about this. And then something just came along. I was kind of like putting my feelers out there, and it was psych care in SNFs. And it was with this company based out of Las Vegas. And, you know, they were kind of coming into the Utah market and they hired me, and I was like one of the first guys that went in. And so that's how I got into it. And a little bit of business background made me a particularly good fit for them coming into a market that they had no footprint in. And so, and then that kind of, I came in as a provider, but also on like the business development side. I think the combination of the two made me stick around. And that's kind of why I'm still here. But if it was like a clinical only experience right off the get-go, I may have not like been super excited about it, but anyway, that's how I got in.
Yeah, I think behavioral health and mental health in general can be really heavy. It's really hard, and it can kind of impact you in a lot of ways. Probably the number one question we get in terms of trying to help is like, how can we help these patients in a skilled nursing facility setting that have some sort of implication or impact from mental illness? And I did some like quick research, and one of the things interesting to me is like mid to late like 20th century, when there were still these psychiatric hospitals, they were trying to deinstitutionalize psych care. And so they started shuttering these down to try to make these patients less isolated. Unfortunately, they didn't really have funding or processes in place. And so a lot of these patients ended up in the skilled nursing facility setting. And so there was really a population shift really in the 1980s, 1990s that really impacted kind of the post-acute care, because this industry wasn't really equipped to be able to take care of these types of patients. And a lot of like crazy statistics, like 90% of the patients in a post-acute setting have some sort of impact from behavioral health or mental health, whether that's like anxiety, depression, to like serious mental illness. And so our providers are now tasked with the responsibility and care to care for these patients. And some of them don't even have training in. Yeah. And so it's like, I know it's really daunting for a lot of these medical professionals to like take care of these patients and really know. So I hopefully today talking with you, Bruno, we're not going to like solve the mystery of like this magic pill or this magic thing that we're going to do for these patients, but hopefully give our providers some tools and understanding about the setting, who the patients are and some maybe takeaway tools that we can really help them. So we're super excited to have you today.
Awesome. Yeah, I'm excited to be here. And I think that's a great question. Excellent starting point with what you mentioned with the shuttering of like the behavioral health institutions. What happened, or let me back up a little bit here. If you broke a hip or if something happened and you end up in a SNF, you are likely not very happy. You are anxious or depressed. Like
everyone wants to go home.
Yeah.
Like, I want to go home.
Yeah,
I get that.
Yeah, you get there and you're just like, I don't want to live here. And so if they weren't depressed or anxious before, now they are.
Absolutely.
And that's that's kind of my mentality. And I kind of joke with people when people ask me like what I do. I went from like all the cool, sexy cosmetic stuff to I try to keep people in skilled nursing facilities from being depressed and anxious, which is kind of impossible, is what I see their mind telling them. Like the people that I'm speaking with, they're like what are you going to do? To make matters a little bit worse, from what you had mentioned with, providers who are now exposed to these patients that have this huge truckload of psychiatric issues with them, along with their broken hip or whatever they're dealing with, are the regulations that came into effect. And so essentially, when all those patients transitioned to long-term care, what happened was people wanted to keep their staff. And you have all these demented people walking around trying to escape through the window, and it makes it really hard to keep night shift staff, day shift staff, and people are like, I have so many patients to care for, and now this guy is derailing my entire day. And so the reaction was, let's give these people medications that will calm them down. And what does that extremely well? Haldol. A Haldol is a fantastic way to tranquilize a human being, and even monkeys and stuff. So, so what happened is we said, okay, we need to keep this long-term care facility staff to care for people. And we don't want this mass exodus because the caring for patients is so difficult. So then the Haldol became more and more ubiquitous in the space. It's not only Haldol, of course, Seroquel, anything that would work. And so then Medicare and Medicaid came in and said, hey, this isn't okay. Like, you can't just like give everybody these meds and have tranquilized people just laying in bed all day.
Right. It's easier to take care of them though.
It's so, staff, like, oh yeah. Now we have staff.
It's great because I know it's like 1 in 5 staff who work in a long-term care setting are physically like assaulted, and like from punched to kicked to like spat on. And so like it's a real problem in terms of like these patients and these staff really taking care of them. And at anyone who's like familiar with the industry knows that it's so hard to keep staff. And a lot of it's just that mental anguish of taking care of 30, 40 patients sometimes. And then you add in a couple of 3, 4 who unfortunately are sundowning or have some sort of behavior and attacked them and kicked them. There's no reason why they're going to stay. So
absolutely.
Totally
true. And it's like, as humans, we want this like a reciprocation. Like you and me, like if I take you out to lunch, I buy you a sandwich. You're like, hey, Bruno's a cool guy. He just like bought me a sandwich. Like next time we go out, you're like, dude, let me buy you a sandwich this time. Like the reciprocation. And we look at that in our employment opportunities as well. And so I feel like people who are getting spat on and spit on and whatever for $18 an hour, they're like, there is no reciprocation here.
It's worth it, I promise.
Right? You're like, just stick around, like, or whatever. And it's like, it's this very difficult thing. And so going back to, the 70s, we're giving all these people these antipsychotics to calm them down, retain our staff, and create some type of like consistent employment pool for our facility. Medicare, Medicaid says, hey, like you can't just tranquilize people. So then what we started doing was we started adding on psychotic disorders to justify the use of antipsychotics.
Because you have to have a diagnosis to match the prescription, right?
Bingo.
And without that, then you get in trouble. So then
exactly
to be able to give the medication, you're going to give them a diagnosis.
Yep. And
maybe
so
sometimes inappropriate. So
yeah, oftentimes. And back then it was. And so we had like 87-year-old John Smith, who was like a productive engineer his entire life, like lived a good life, raised his family, came down with Alzheimer's or whatever. And now all of a sudden he's schizophrenic, unspecified. and at 87, and that's when the Omnibus Budget Reconciliation Act, OBRA of 1987, came sliding in, and everything we're going to talk about today is a sliver of OBRA. And basically that is going to come down on you in surveys for the facility and things like this. And so basically what we're looking at is, in order to prescribe an antipsychotic or a psychotropic medication, which is not an antipsychotic, so like a dementia patient with major depressive disorder that had major depressive disorder before they came down with Alzheimer's or whatever, they could be prescribed an antidepressant. That is a psychotropic medication. An antipsychotic is not necessarily the same thing, and they're treated a little bit differently in the space. But essentially what we're looking at is, if you are going to prescribe an antipsychotic, that patient, OBRA wants you to justify that with an actual diagnosis. So, if you are schizophrenic, typically you're going to have had like an event early in life, like 17 to 25,
right?
Where something happened. You were naked running around in the mountains. You were stealing Snicker bars from Albertsons, right? And you ended up in the hospital or in jail or something. If that doesn't exist, it becomes a little bit trickier to justify adding on a delusional or psychotic diagnosis late in life. And a lot of times that's what OBRA and the surveyors are trying to find. If you did prescribe this, where's the history? A lot of times we can find that in a PASAR, and we were talking about that a little bit before.
Yeah. I think one of the things that also complicates this, so like they're in acute setting, so they go to the hospital, they broke their hip, right? So they're already in an environment that they're not comfortable with. In the hospital setting, if you're having some of this agitation behavior, there's those medications that are appropriately used, like sometimes Haldol, sometimes Seroquel, sometimes like Trazodone, to really just help get some of that sleep. They've been fine because they've been on those medications, and now like, they're doing better, not quite good enough to go home. Let's send them now to a skilled nursing facility. But now at a skilled nursing facility, I don't have those tools to be able to really take care of them. And now the individual doesn't have those adjunctive therapy medications to be able to help them. They're not in their regular environment. Maybe they've already been dealing with some mental health issues at home, but masking it, or they have like early onset dementia or suffering from dementia, but they're in their own space, so they can kind of mask it, and the family doesn't notice maybe little things. But now we're in an environment where this is like full blown, and like they're completely out of it, and sundowning, and they're screaming, and they're like, my mom's like not like that. And they have this poor CNA or nurse who is again taking 30 patients, who like is just kind of desperate, and they're reaching out to a provider and saying, help.
Yeah. What do we do?
Like what? And we don't have those tools readily available. Plus there's not enough training or funding for staffing, but also education on how to help these poor staff to be able to take care of these patients. So it's really difficult. That's
exactly right. And I do have some comments on that, on the funding aspect of things. But you're 100% correct. And we'll go into some books and papers that people that are way smarter than I am wrote about this topic and what should be done. But ultimately, let's jump into the actual tools that we can utilize without getting in trouble. I'd like to go over that, and then we'll go into like the non-pharmacologic
and
interventions if possible.
Because I think the scenario is like, I've been on call hundreds of thousands of hours. Like you get a phone call at 2 a.m. You're like, oh man, Mary, who just admitted yesterday for a hip fracture, is like running around the facility. Well, not literally running. She broke her hip, but like she's trying to, and she's yelling and she's hitting. Like, is there something I can give her to like just help her sleep or help her calm? And I think most of the intention behind it really is like a good intent. Like we want to keep them safe. If she's walking around and gonna fall, that's not good for them. But like we also need to help the rest of the patient's sleeps. And so like some of the medications I like, normally I work in the acute care setting sometimes too at the hospital. I'd have a lot of tools in there, but then I feel like a lot of ways my hands are tied in a nursing facility, because I'm like, well, we can try melatonin and that doesn't really work. Like maybe we can like stretch out and use like hydroxyzine,
right?
Like for itching. which is like in the Benadryl family, and maybe that'll make them a little bit sleepy, but like the Beers criteria kind of negates that too, and we don't want that to build up in their system. So like previous, in a lot of ways, people would just send them to the hospital because they're like, I can't take care of them here. Like they're not safe, they're disrupting, and so that's obviously not a good tool for them too. So what are some like medications that are like generally good things to like reach for and like help?
So that's a great comment. And I'll one comment there, like when we do send the patient out to the hospital, there are implications like costs to our medical system. And I know that like we say that nobody really cares, but just creating a more efficient society is like, I find that to be somewhat motivating with my job. And then as far as the facility goes, when they're sending people out constantly, it actually hurts them and their prospects for like better patients. And so, and sometimes
there's so many like moving parts.
There's so many moving parts, but let's jump in. So one of the major things that we're looking at is, as a provider, you can prescribe those things. Chance. It's just I'm
terrified too, though. I've been
told
not
implications,
to,
right? There are implications, and there are issues like when it comes to like the benefit versus the cost to the patient with using those kinds of things. Like for example, if you're prescribing benzodiazepines for a patient like this, you're giving them alprazolam or something, 1 milligram Q12 due to their behaviors or whatever. If that becomes routine for that patient, then we don't know if they're agitated because they have Alzheimer's, or they're agitated because they want more benzos, or they're withdrawing from benzos. Right. It's like then we're adding another variable. That's one of the issues that it's bad. But let's talk about some things. Hydroxyzine isn't a terrible option as a PRN. Typically, I'll like to load with something. So I know Depakote is coming under a little bit more scrutiny right now with CMS, but there are patients that have done really well where you can load with like 500 or 750 milligrams if kidneys and liver and everything allow or permit. And then the hydroxyzine tends to have a little bit more impact if they have a little bit of that loading.
Rather than just like hydroxyzine by itself.
Yeah, rather than hydroxyzine by itself. But you have to be careful because not all mood disorder medications are going to create that impact. So lamotrigine tends to be more activating. And so you can't just reach into the behavioral or to the mood disorder family and just pull stuff out. And so like, for example, lithium, like these are frail individuals. It's just going to wreck their kidneys. It has actually a lot of research behind it for the elderly, and it has some decent outcomes. I think people are scared of it because you have to do all this monitoring and get the lithium plasma levels and all that stuff. But the Depakote loading with something like an antihistamine tends to have more impact. Something else that I've noticed in facilities here in like Utah, in central Utah, is giving Namenda to patients. So you start at like 5 milligrams BID and then increase to 10 milligrams BID. Nothing that I say today is going to be a home run every single time.
And is like Namenda, does it have to have like a proper like psychological diagnosis with that? That's what my understanding was behind that. Or is that can be like an adjunctive PRN just for agitation?
It wouldn't be like PRN. It would be scheduled. It would be scheduled. And so you typically want some type of cognitive disorder associated with it. And so we're not typically prescribing it as a supplement.
Right.
But yeah, we'll start at 5 milligrams BID. We'll go up to 10 milligrams BID. And I would say 30% of the time, it is night and day, and it is sustained success for these patients. So we've had patients that are naked, they're throwing feces on the wall and stuff like this, 3 weeks on this like Namenda train, and a year later, it's night and day. People still talk about it. And so I've had success here in the Provo area. I've had success with that recently, like as recent as the last 4 weeks in Cedar City in Utah. And so that's a really off the beaten path. Like, this is an anecdotal. I can't say that I can point to a lot of research that backs us up, but from my perspective and working in these buildings with these facilities, that is something that has had success in one location, and recently we're like bleeding it out into others as well.
Yeah, what I've also found is like I think providers in this setting are a little bit more comfortable reaching for like
the benzodiazepines,
but they're like a lot more comfortable to reach for like those medications rather than like try to like spend a little bit of time to like research maybe some of these other medications that'll help them over in a long-term case.
Yes.
But even before that, I'm always telling providers like, let's try to take like 2 steps back, right? So sometimes these patients were on medications at home and that inadvertently got stopped while they're in the hospital. It wasn't caught in the hospital. They were discharged. And so like doing a little bit of digging often helps, like, oh man, we kind of abruptly stopped this medication that their body was used to in terms of like processing. But I think the other really important part too is like, why do we think they're like behaving this way? And one of the things that I found really in this setting is really pain related. Yeah. So like some of these patients are just really acting out, not quite sure how to communicate that like something's off or they feel off. And so like making sure that we're addressing pain appropriately. We're not missing like a fever. We're not missing some sort of UTI management as well. And we're not just chalking it up to some sort of mental health or break or agitation in that setting. So looking at the bigger picture, I think is
right.
Like the point of like OBRA, even though I think there's a lot of like angst around OBRA, like negatively.
It has reason. It oversteps a little bit, but I mean,
like people get scared. And so then like the pendulum swings in the other direction. So making sure that we're looking at the overall bigger picture in terms of like reaching for medications, but also being careful because you can reach for a pain medication and that can be sedating too. And maybe that's also not inappropriate. Like can't just reach for oxycodone to sedate a patient.
You're completely right. And I think that sometimes, so what happens, Chance, is vital care providers are getting the result of the broken system, right? Like that's like and so we're trying to Band-Aid something that broke a long time ago, like in the cascade of the treatment. And so sometimes people try to do things that are going to be helpful. Like, oh, this patient had major depressive disorder. Like back then, maybe they're depressed, maybe if we treat their depression, their behaviors will come down. Let's throw some sertraline at them, 100 milligrams or 150 milligrams. Well, some of the psychotropic medications have activating qualities. So like fluoxetine, Prozac, sertraline, Zoloft, those medications often result in greater activation of a demented patient, causing them to stay up late, causing them to walk around. And so you think you're helping and you're like you're kind of toying with things. You're actually making it worse in that situation. And so you want to do a little bit of research. It won't take long. We got a lot of cool tools, ChatGPT or whatever, to figure out which psychotropics are going to be activating for the patient and opt for others that won't, if you do think that the kind of reason that they're acting out is anxiety or depression or whatever. I wanted to plug that in there, but if you would allow, the most important thing that we're going to do here, and the reason there isn't a solution to this yet, is because the solution is likely non-pharmacologic in nature, and implementing that system wide. That is why this has been a problem for dozens of years, and we still don't have like a solid solution. So I'd like to explain what I've noticed and you guys have been in a bunch of different facilities. I think you'd agree with me. Rural facilities tend to be closer knit, not only the staff, but with the patients. Like they see.
Well, the staff knows their family. They grew up with their family.
Absolutely.
They have a little bit.
Absolutely.
A bigger understanding of who the patient is.
And the most effective, cleanest, just great team environment, great patient outcomes, even in locked units, are in rural communities. And so if you think about that, like everything that I have to say about non-pharmacologic interventions branches off of that tree is great. So we have a team that has been a team for a long time because there's not as much turnover in the rural facilities. We have teams that work together. They know they're going to be together for a long time. Therefore, they can make that they can reciprocate with each other, like we discussed earlier. And they say, I'm not just going to leave Mary in the locked unit, just getting wrecked all day and like be out here eating like my Arby's sandwich.
Yeah.
They work together. They know that they're going to have to work together for a long time. And they have those community relationships with the patients. And so they have like these ingredients that all the books that I've read on non-pharmacologic interventions for dementia management and all this stuff is essentially saying that is there has to be some type of buy-in, if not for the patient, for the team in working together. That's why it's so hard in a urban environment to recreate that. There's too many employment opportunities. Nobody knows each other. And when things get hard, they just bounce. Right. And that creates this like disarray in a locked unit that when the patient lands, that then the CNA has 30 patients. Like they didn't want an admit. They're already pissed that there's an admit. And now the admits doesn't know what's going on. Yeah. They're off of Seroquel that they were on in the hospital. And, they don't see any of their loved ones. And so this is something that I would say I'd like to break it down for the listeners to understand like what the components are of that.
Yeah.
And so number one is what we need to understand is what creates sundowning. And typically what creates sundowning is the appearance of chaos to the demented individual. And so when things are chaotic and things like this, they want to escape. It's uncomfortable. They want to leave.
It's like survival mode.
Yeah, survival. I was like, I need to get the freak out of here. And they have pain on top of that. They may have some stuff that they're carrying with them as far as behavioral health goes.
They don't know where they're at. It's not like a new
They don't
environment.
know these people. Yeah. Everyone's in a rush and flustered. And so they're just like, get me out of here. Like, this is freaking me out. And so number one is what the research shows is front loading the day with activities and things and structure is extremely beneficial to avoiding sundowning. And so if the demented patient feels like at the end of the day, we're trying to play catch up, we're trying to rush them to dinner, rush them back, like still finishing up showers because we were late. There's shift change at 6 or 7 p.m. That all is contributing to sundowning. Okay.
You're like explaining a normal everyday skilled nursing facility environment.
Absolutely,
like this happens every day.
Absolutely. Yeah. But Chance, in the rural communities, it doesn't happen to the same degree. They can almost like keep a lid on it all the time. They have a pulse on it. And I think they know it. They know, they don't like systematically do this, but just by the nature of being a team, they're like making shift change not seem like such a big deal to the patients. It's like a little bit quieter and things like this. So number two, so that's number one, is like front load the day with stuff.
But you also have like the day shift who's like, whew, Mary's sleeping. We're just going to let Mary sleep. She's a lot easier to deal with if she just sleeps. And then she sleeps all day. And then they're like, shift change.
Yeah, we're
going to wake up Mary. And Mary's like, where am I? And then they freak out. But day shift's like, well, I'm going home.
That's right.
Poor night shift.
See ya.
Here they go. Like, right.
See ya. And that's the truth. And that's actually another, some of like the experts in this area, they also mentioned that naps are not a good thing for demented people, which is like, that's like what they're hoping for. Yeah. Like when I go and I'm like,
please take a nap. Yes. It's like having a child again. You're like, oh my gosh, please take a nap.
Please just take a nap. Yeah, I have so much to do. I'm late. I'm late on my charting. And so when I show up, they're like, no, don't see John. He's sleeping.
He's like, no, I'm I
gotta talk to him. So that is another issue is like, it's a whole cultural revolution that we would need to essentially do. So what I would say is parallel to the skilled nursing facility or the long-term care facility, there has been great improvement in caring for a demented individual at home. And so when people do implement all of this stuff that I'm going to say, it actually does yield results. It's just very difficult to do it system-wide in a skilled nursing facility. And I want to speak to like some solutions to that as well. So front-loading the activity or activities in the day, making sure that we're winding down by the time dinner hits. calm music, the like familiar smells. Like you could have a diffuser or something that's like eucalyptus and it turns on at like 4:30 every day. They don't know it, but and then you can like dim the lights, and then some sequences could occur with that trigger that tells that patient, oh, the eucalyptus is coming out, it's time to chill. And they'll essentially like play ball if you can do this consistently. Something else is some structure to the schedule, like every single day. It's the same thing. That will help the patient avoid deviations from that structure. Like they want it. The demented person wants structure, and when they don't have it, that's when all the chaos happens. And other things like simple language. And research shows that the language isn't as important as the tone. And so if you're just like, Barry, dude, stop, just go back into your room. Like it's over. You lost, Yeah. But if you're like, Barry, where are you going? Like, where are you going, man? And like kind of playful or like kind of calm, that typically will result in like some type of improvement in like the frequency and intensity of sundowning. And so those are some things where people are just like, how exactly are you going to do that? And that's where I want to talk to you a little bit about, funding, like new funding that's coming in through states and things like this, that could be very beneficial to something like this, get more boots on the ground. And I don't know, Chance, I'm sure you've seen, like there's always a carrot dangling in front of skilled nursing facilities with a new funding program. Right. And so I'm very hesitant with this kind of stuff.
Well, because someone has to fill it out, someone has to track it, someone has to report it. Like it's not as easy as it sounds. Like here's money for that. So
and it's unreal.
It's complicated.
It's just unrealistic for a lot of facilities to take it on themselves. And so there is a successful program out of Nevada where there was a bunch of homeless people and it'd end up in SNFs and they're like, we don't want to deal with this. And so they'd ship them off to California, and then they all go to Skid Row, and then it becomes like this metropolis of homelessness and all this stuff. And so California's like, hey, you guys got to figure it out. And so they came up with this program where they incentivize, financially incentivize facilities for keeping those kinds of patients, the behaviorally complex patients. And it's a meaningful amount of money that's coming into the facility. And the purpose is for additional staffing, to get an all-star that can teach the nursing staff, the nurses, the CNAs, and everybody, the stuff that we just talked about, but not only teach it, but like be a constant presence of that. And that's what we'll need, is an all-star who is like at a skilled nursing facility for years, not months, teaching this stuff over and over and over again. And it becomes like a standing environment, like a change in environment for the employees, where they come to expect this type of work life when you work in a skilled nursing facility. Like the eucalyptus stuff and the lights and like all this stuff, it's got to be a long-standing thing. And so the purpose, or the idea with this funding, is that you can find those highly skilled individuals that can not only implement the interventions, but can teach it effectively and have them in facilities all of the time. And so part of my job here at Gadzoom is to help partner with facilities to create something like this, a constant educational presence in the facilities that isn't fleeting and changing the actual culture associated with working in a SNF, if that makes sense.
Yeah, that's awesome. I think there's so many resources available out there. It's just knowing and having the time to be able to do it, right? And that all sounds great, Bruno. But like 2 a.m., like Mary's freaking out, like eucalyptus, like you're gonna blow eucalyptus at her.
Nope.
Like you're gonna like
flash dance party.
Like what are you gonna like just talk quietly and calmly? Like it's such a hard struggle, especially in the acute kind of setting and nature of like kind of that mental health, or dementia with agitation, because like really you're this poor nurse and this poor CNA, and we've talked about it a ton already today, is like they're just like overwhelmed, and so like on the provider side you're like, well, just like do eucalyptus, and I'm not meaning to mock any of those things, because I think those are all very important things. Like what are some like tools in like that acute setting where I'm at my wit's end right now, I want to do the best I can, and my provider's not going to give me Haldol, Like what are some things that I can do in that setting to like that would help redirect appropriately and maybe like put them in a better, safer environment for the patient?
Sure. So there's two things. I totally agree with you. And even if you do everything that I said perfectly, you have like all-star Donna who just like knows what she's doing, teaches all the staff. There's these minions that are doing everything that they should. You will still have sundowning. You will still have people going off the rails 100%. Yeah. So I agree with you. So number one, I want to skip to like the more aggressive approach here, which is they're going to hurt themselves. Like they're trying to stab people with a pencil. Yeah. We need to keep them safe. And so you can use pharmacologic intervention in those situations, but you need to be good at charting and you need to understand what CMS is looking for. And so if somebody is going to hurt themselves or other people, and I have been in facilities, I know that you have as well, where people like have gotten beaten up by a demented guy. Right. A situation like that needs to be avoided. It just needs to show in your charting. So you say, these are the interventions that we tried. We tried eucalyptus. We tried calming music. We tried turning the lights down.
Bruno told me to do all these things and it didn't work.
I did, and it didn't work. So Bruno sucks. And now I'm dealing with Susie at 2 a.m.
Yeah. Bruno's at home sleeping.
Yeah, he's chilling. Yeah, and he's going to the a ball game tomorrow morning on Saturday.
He's doing fine.
Yeah. And so in a situation like that, the provider needs to know what they're doing. And they need to say, they need to lay out the interventions that we've tried. So like the provider, for a vital care provider or somebody would talk to the 2 a.m. nurse and say, what have we tried? And you would document that stuff. Oh, we've tried this, and this, and this. Okay, in my note, we have tried these non-pharmacologic interventions for Susie and it's just not working. She's escalating and is getting to a point where she's going to cause physical harm to herself, other residents, or staff. Okay. That wordage right there is going to, the facility is still going to get some type of implication for using antipsychotic or whatever for a non-psychotic patient, but that is going to keep them from getting like a serious tag, like an F tag or J tag or something like this. And so if you can justify it and there is some type of termination after, like this was like a one-off thing. We're just trying to like take care of Susie. It doesn't happen all the time. Then you're okay. You can do that. You just need to justify what you're doing.
The other thing that becomes complicated, especially when you're using pharmacologic interventions, is like these become open-ended. So like a well-intended acute setting provider starts a medication to help and then it gets left on their MAR. And then like 5 years later, they're like, oh, they've been taking this medication every day and they're great. But really, like you said, I think documenting appropriately, like this is why I did this. This is how I did it. And this is like kind of the parameters that I want to operate that within, like 3 days total until maybe a like more psych professional can come in or the medical director can come in and do a broader evaluation working with a pharmacist or whatever. And so what I like to do is like, even if I do have to reach for like a benzo for safety reasons, one, document appropriately, like you said. But also like put a stop date on it. So like absolutely. I'm only going to let you have it twice. So like you can use it once now, and 3, 4, maybe 6 hours later, you can use one more dose if needed and then stop. And I think that's the other thing is a lot of these patients are just on so much medication. So like, again, well-intended, like we're going to start this to help. And now they're just kind of left on it. And now they have, no joke, 30, 40, 50 medications on their MAR. And who knows what medication's doing what. And so making sure we're strategic on the medications we're giving, but also giving like parameters, strict parameters on how those are given. Absolutely. And what should happen is a good psych provider should come in behind you in that situation when the 2 days is up and, perform a psychiatric assessment. Like, what's this patient's background? Like, what would be helpful? What kind of like systems could we put in place or teach the staff to do to decrease the prevalence of the sundowning or the acuity of the sundowning for the specific patient? And then the facility and the psych provider that's working with the facility should be holding monthly meetings. We call them like psychotropic meetings or GDRs, in reviewing what happened. Okay, we see that Chance threw in a 25 milligram Seroquel 2 times. That dropped off 2 weeks ago. Staff, what happened? How did that go?
and have a discussion on like, is this something that, we should go back to in the future only when needed? Maybe the success or the failure of that could be, could result in some new treatment formula that we come up with as a team. Like, that shouldn't happen if you have good people that are helping direct the psychotropic situation of the facility.
Yeah. I think the more you get to know the patient too, and I appreciated when you talked about like that more rural setting where they understood who the patient was. Everyone kind of knew them. I like reflectively while you were talking, I thought about this patient that we were trying all these things. And they were just really horrible until like 2 or 3 in the morning. And then we discovered like his whole life, he stayed up till 2 in the morning. That was his schedule.
Yeah.
That's what he did.
Like an oil worker or something.
And so what they found is like if the staff would like actually brought him out and they just kind of kept him around the nurse's station. And then around like 1:32, like we start winding down. And this is kind of a different setting, but like then he was fine. But in his like whole life he stayed up till 2. So I think in the other term and if we had the time, right? Like we want to get to know these patients, who they are and kind of their background. And I think that helps. And that's why this is so complicated because like every patient's so different.
Yes.
Like every staff is like different, and not to mention, and I think it's worth mentioning, like some of these staff members are also dealing with like some mental health issues. Like healthcare is like riddled with like anxiety and depression. They have things that are going on outside of their life. And now you bring them into this acute stressful situation and they're supposed to be calm and so like it's just compounding. And so I think mental health across the board is like really difficult. And then you put them in a skilled nursing facility setting that's just exacerbated like across the realm. And so yeah, I think overall the topic is just so hard. So
it's extremely difficult, and it's just not I think everybody wants just like this one size fits all solution, but if it were that, it would have already been solved. And I stand by the reason this is so challenging is you have to change the culture of the SNF. And you have to come up with some type of protocol that is educational and is actually absorbed by staff. That is very challenging. Like people always are doing like these staff trainings, like here's the fire hydrant. This is where you exit if this happens.
Well, you have to do that. You have to mark it for your survey.
Exactly. Right? And it will become just that. But this is something that like people need to understand. If we implement like legit non-pharm interventions, like a cascade of things that we do, and like rinse and repeat at every facility and like don't let off the gas, it will make work easier for everybody who works in a SNF, and it'll make life better for all the dementia patients that are present in a SNF. And it'll, Vital Care won't get as many of those 2 a.m. calls for that reason. Yeah. And so it's so challenging, but I've seen it done on small scale. In rural communities, it can be done. It's just really hard to replicate that. And so part of why I'm still in SNF is like, it's a problem that like, I think you can work on almost forever. And I think you can improve, but you need so much buy-in from so many different people, so many different walks of life. But yeah, it's a challenge, but I've seen success. I've seen it done right.
That's awesome. No, thanks, Bruno. I think in summary today, like the thing I try to help people understand is like there is some pharmacological like interventions and they're necessary sometimes.
Yeah.
To not be too afraid of them, but be strategic and like document your thought process so that it's explained for others who are following, and making sure you're putting really strict parameters on that so that it just doesn't get stuck on their MAR, but also pushing kind of like this cultural change that you talk about in terms of the SNF. Like these are real individuals who like were doctors and engineers and like really cool people who did really cool stuff. And that's what keeps me in the setting is like, I think we really in this setting can really make a huge difference. So I appreciate your insight in today. So we're going to switch a little gear just to end up here because we love doing this. Okay. I'm going to have the title of our podcast is Sniff This. So you got to sniff a couple things. Okay, Bruno, are you up for this?
Yes, let's do it, man.
Okay, so you can smell it and just see if you can name the smell for me.
In a urine collection cup? You have to. It's like part of it.
You have to. It's like part of it. 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 It's like part of it
It seems like alcohol.
It's pretty close. Just hand sanitizer. Like that's like I'm not gonna like do something gross here for you.
That'd be wild if
like
you did. That messed me up, man. All right.
Maybe another time.
That smells like.
You could taste it if you want.
I'm not tasting that. Man, that is a smelly smell that I've smelled before. I'm trying to think.
Do you have kids?
Yes, I do have kids. It's like a cherry. There's like a cherry like cough medicine type situation here.
It's Tylenol.
Tylenol.
It's just children's Tylenol, which is actually like in terms of like liquid Tylenol. That's what we use in the SNF setting today.
Dude, that's pretty good.
Awesome. Thanks for being with us today, Bruno. I think we'll probably have to schedule another one. There's so many ways we could go with this.
I actually have like 2 pages of notes that we didn't even touch. So I had like specific doctors and PhDs and stuff like that that wrote like books, but most of the books are for at-home use. They're not for SNFs. All the books also, by the way,
which is really irrelevant. I think people would be interested in that.
So. Oh, I think it's necessary because we can borrow some of that stuff. But all of the books say, when all else fails, don't feel bad for sending them to a facility. And then we're sitting here having a podcast about what happens
on the
when
other
that
end.
happens. Yes.
Yeah. Well, what we can do is we can link some of that to our podcast if people want to dive into it a little bit more.
Yeah, I can send that
information. And we'll put your information if people want to reach out.
Okay.
Too, but. Really, thanks for being on today. And we're excited for next week. Please join us for our next episode of Sniff This. Before we conclude, huge thanks to our sponsor, VitalCare Connect. Whether you're burning the midnight oil or just trying to survive another 2 a.m. call, VitalCare Connect provides on-call medical director support whenever you need it, nights, weekends, and holidays. With coverage nationwide, they're leading the way in post-acute care, elevating quality, expanding access, and supporting well-being for all. Learn more at vitalcare.org. Thank you for joining us for this episode of Sniff This. Share this show with your favorite CNA or anyone who's survived an all-staff meeting fueled by cold coffee. Until next time, I'm Chance. In skilled nursing, if you sniff something, say something.